Hello, everyone, and thank you for attending today's webinar, Strategies to Maximize BPCI Reimbursements with Patient Education, presented by HealthWise. I'm Alicia Caramenico, contributor to Fierce Markets, and I'll be moderating this webinar. Our speakers today are Josh Sly, Director of Product Strategy and Experience at HealthWise, and Adam Husney, CEO and Chief Medical Officer at HealthWise. You can read their full bios on the right side of your window. I have a few technical notes before we begin. The webcast is being streamed through your computer, so there's no dial-in number. For the best audio quality, please make sure your volume is up. You can find additional answers to some common technical issues located in the Help button at the bottom of your screen. This webinar is being recorded and will be available on demand within 24 hours after the event. And we will follow the presentations with a Q&A session. Please submit your questions using the Q&A button on the left side of your screen. Now I will turn it over to Josh to get things started.
Thanks for the introduction, Alicia. And thanks to everybody on the phone for joining us to learn a little bit more about the recently launched BPCI Advanced program and how your organization can optimize clinical episode successes through patient education and engagement. So as Alicia mentioned, I'm Josh Sly, and I'd like to kick things off just a bit with an overview of BPCI and how it's changed the reimbursement landscape. And then we'll talk a little bit more about how patient engagement and education come into play. So as we're all aware, the healthcare industry continues to shift from a fee-for-service model to a value-based environment. And that spurred a growth in a number of alternative payment models. And as part of that growth in value-based alternative payment models, bundled payments have become a key component of the transition towards providers assuming and sharing more risk. And as you can see on the screen, as much as 29% of healthcare payments made were actually under alternative payment models, which represented a 6% average growth year over year. Also, as consumerism continues to rise and patients become more cost sensitive due to the prevalence of things like high deductible health plans, there has been a parallel growing interest from consumers that value-based care models provide mutual accountability. In fact, a recent poll suggesting that 78% of consumers like the concept of bundled care because it provides greater clarity and transparency to how healthcare is actually paid for. And when it comes to the transition to a value-based environment, bundled payments actually represent a pretty significant step for many healthcare organizations. The transformational change away from fee-for-service has now picked up significant steam. In fact, CMS announcing over 1,300 participants in the new BPCI Advanced program. It's a pretty impressive trajectory for health systems across the country as to their appetite for accountability and their confidence in their clinical operations. But bundled payments aren't anything new. They've been around for a few years. But under BPCI Advanced, providers must now manage risk over a longer clinical episode length, meaning an increased focus around controlling costs through appropriate follow-up care post-discharge. And case in point here, inappropriate care settings have historically been really costly. And looking at claims data, 13 to 27% of emergency department visits have been shown to exhibit inappropriate care setting with the severity of the condition. And having these patients search for the appropriate level of care, for instance, at an urgent care clinic, should that be appropriate, actually could save the healthcare industry $4.4 billion annually. And for those of you on the phone that work in a healthcare organization with an ED, I'm sure you could probably attest to some of those numbers. So why is there so much participation in the new BPCI Advanced model? Well, providers are drawn to the model's potential for a few reasons. First, to manage operations and costs to maximize their financial viability. Also, to share risk amongst numerous collaborative entities or conveners. To have their payment adjusted according to their case mix retrospectively. To still improve their overall volumes. And to maintain or improve care quality through accountability to things like quality measures, which they've been working towards for a number of years. But what's the bottom line? The major difference between previous BPCI models and BPCI Advanced. Now, whereas in previous BPCI models, a lot of the accountability is related to keeping costs low, BPCI Advanced incorporates those quality measures and those adjustments for case mix retrospectively, in addition to lowering the cost. But as with any risk arrangement, there are challenges to optimal success. And as I can attest to, having worked in a cross-functional role in a health system for a number of years, any major shift in operational focus requires a great deal of planning, thought, and of course action. And now I'm going to hand it over to Dr. Adam Husney to talk a little bit more about some of the challenges we see in engaging the health systems we've worked with and healthcare organizations across the country.
Thanks, Josh. So as providers move towards value-based care, they have bigger incentives to provide the highest quality care at the lowest cost. And this really aligns patients and providers nicely. In this paradigm, keeping people healthy at the lowest cost is both good for patients and good for health systems. But it also highlights the need for providers and patients to not only think about treating diseases, but to align on healthy preventative behaviors as well. And these are things like improving diet, staying active, stopping smoking, and taking medicines appropriately. As providers, we aspire to be and often believe we are good communicators, but our communication is often not as good as we think it is. I've heard of patients trying to put oral antibiotics in their ears and people waiting with abdominal pain while their appendix perforated just because they didn't understand the information that was told to them. In fact, patients are under stress from serious health conditions, and the information they hear can be complicated and really unfamiliar. And as a result, they forget a lot of what they hear from their providers. And worse, the information they remember is often remembered incorrectly. And there can also be communication challenge within healthcare systems. The various care providers, from inpatient to rehab to care managers to the ambulatory teams, often don't communicate seamlessly. Often there are multiple electronic records, and these are disparate systems which really lead to poor visibility across all the care settings. This makes it really difficult to deliver consistent, personalized, and effective care messages to patients.
So those are some pretty hefty challenges, but although there are those big challenges in taking on additional risk through alternative payment models and bundled payments, success is absolutely possible. In fact, there's ample evidence that it's possible. As you can see on the screen, recently a large urban academic medical center, NYU Langone, was able to decrease their average 90-day cost per episode by 20%, reduce their length of stay by 17%, and reduce their 90-day all-cause readmission rate by 5%. And all of this subsequently helped them achieve lower costs overall. It helped them retain more of that reimbursement. And as always, what we're looking for is to produce better patient outcomes. And they did this by focusing really targeted efforts around their bundled payment episodes. Similarly, Baptist Health System recently saved 20.8% per episode in lower joint replacement surgery with their participation in BPCI. So again, success is absolutely possible. But where's a good place to start? So I think it's useful for us to check out some of the best practices and hone into areas where you could optimize right away for the episodes that you're participating in. Although there's no silver bullet, there's no single pathway to accomplishing the goals to BPCI and BPCI Advanced, CMS Innovation Center has actually identified 7 ingredients to success. So first of those is strategic partnerships to promote care coordination and data sharing. Now this can be in the form of working closely with your conveners and perhaps in the form of acute care hospital and post-acute care providers working together. Talked a little bit about communication, so optimizing communication between those providers, sharing data amongst risk-sharing entities, allows for a 360-degree view of the patient. All of those things are going to be really important when you work through strategic partnerships. Efficient and appropriate staffing models is second. Now, communication between providers, standardized clinical education, and opportunities for input from cross-functional areas are really important in gaining buy-in for a streamlined, seamless clinical care experience, both on the staff side and on the patient side. Third, patient identification and risk stratification. Now, using technology is the best way to do this in identifying patient needs, such as barriers to seeking follow-up care and medication adherence reminders to help them reduce the amount of unnecessary follow-ups or any potential crisis point interventions. Next is effective clinical and financial management. And developing standardized care protocols and identifying opportunities for cost savings through areas like supply chain management have been shown to increase the likelihood of success and financial viability. Fifth, data-driven program management. There's a lot of talk out there about big data, but by using data sharing best practices and tracking key performance indicators amongst providers and staff to achieve preset goals and having socialized those goals, everyone can be on the same page about their processes and what the outcomes are. Sixth, continuous quality improvement. It's always best to engage, if you have one, an internal Lean Six Sigma team to identify areas for quality improvement throughout the entire clinical episode or episodes to eliminate waste and catch potential gaps in patient or clinician experience. And then finally, patient and family engagement throughout the care continuum. And this is one area that we often see underutilized as part of a comprehensive approach to strategic planning for these episodes. And that's, again, engaging patients and families. And having worked in a health system environment myself, this is an area that we put a good deal of focus and investment into, as it was the area that we could offer pretty significant opportunity to lower and control costs with a fairly low level of investment in labor and equipment or other resources. So now that we've gone over those 7 primary drivers of success, I kind of want to go over the impact of patient education specifically. And as pointed out through those CMS Innovation Center drivers of success, one key component of patient engagement is actually education of the patient, the family, and caregivers throughout the entire care continuum. In fact, there's proof to this. One BPCI program study concluded that a clinical pathway emphasizing patient education resulted in an episode cost savings of 13%, pretty significant. But we also know that buy-in from clinicians on new approaches to their interactions with patients is vital. So without their support, new initiatives have the chance of failing. However, clinicians are believers in this as well. They're believers in an increased focus on an impact of patient, family, and caregiver education and engagement. In a recent survey, upwards of 75% of physicians are linking patient education and engagement tools with improved patient experience. And I really like this quote from the CMS Innovation Center. He said, patient and caregiver engagement increases the likelihood of better health at lower costs through patient education and ongoing communication throughout the clinical episode. So how do we achieve the best practice of engaging and educating the patient and the family throughout the entire care continuum? Well, first, the approach requires tried and true strategies around the entire care continuum and full clinical episode or episodes. And to do that, I think it's incumbent upon us to give you a few strategies. We're going to give you 3 strategies that we think will help make an impact with patient education, and some of the ways that we've actually seen some of the most well-known health systems across the country achieve success in engaging and educating their patients, the families, and caregivers. So the first strategy is to standardize patient education across your enterprise. So I'm going to ask you, Dr. Husney, can you tell me a little bit more about why it's been important to the health systems that we work with to have a single source of education for all those patient interactions?
Sure. So it's hard enough for people to understand complicated messages when they're delivered accurately, consistently, and in language that the consumer can understand. But it's really impossible when there are barriers in place. Patients hear messages from many, many different places. They have many clinicians, including physicians, nurses, physical and occupational therapists, just to name a few. Having a single source of truth using one voice that's evidence-based, updated continually as medicine changes, written in language that patient can understand, and consistent across all care settings is really the first step and a necessary step to engaging people with clear, actionable information.
Great. So drilling down a little bit more, the second strategy we've identified is to really focus efforts around existing care plans and clinical protocols. And this comes from previously identified clinical pathways and making sure that you map the patient journey across the clinical episode. So Dr. Hudson, I'll ask you again, can you lend a bit more insight on how successful provider organizations have ensured that each patient is receiving the same consistent information at every one of those touch points throughout the clinical episode?
Yeah. So in the same way systems use clinical care plans and clinicians use those care plans to deliver high-quality, consistent care to patients, you need to think about educational care plans as part of that high-quality care. So we've worked with organizations that have the greatest clinical care plans, but no corresponding information for the person who that care is about, the patient. We help them connect educational points to all of those important clinical touch points. You need to deliver the right information to people at the right time in their unique health journey. And that information needs to run parallel to be connected to those clinical care plans.
Great. So in the spirit of patient-centered care, really the cornerstone of those value-based risk-sharing arrangements is that patient-centered care more than anything else. And as part of that, we need to make sure that we're sharing data, we're having communication across the episode, and we're coordinating appropriately. How have you seen healthcare organizations share data, communicate with each other, and help coordinate with each other to accomplish some of the aims they're looking for?
So I would agree that patient-centered care is the cornerstone of all care and the kind of care that you all aspire to provide. And with value-based care and bundled care, the systems are better aligned to keep the patient in the center of that care. So I think of it as a big sphere with the patient in the middle, much like Da Vinci's Vitruvian Man. So now imagine clinical care plans, patient preferences, patient education, electronic records, and all care providers can sit on the outside of that sphere looking into the patient. And all those parties can look across the sphere and have visibility to what is happening with that patient. This can help improve workflow, understand the clinical and personal needs of the patient, and increase transparency across all care settings. And that visibility can only help improve care.
Thank you. So now that we've gone over those 7 key ingredients for success from CMS, and then subsequently the 3 strategies around engaging and educating patients and families and caregivers, you sort of have a starting place to make sure you can achieve that engagement. So I think it's important for us to next look at an example, and an example that sort of emphasizes that Vitruvian Man sphere scenario and how the patient can be engaged and educated throughout the episode of care. Now, although we do know that not all BPCI episodes are surgical or elective, for the sake of example, we've decided to talk a little bit about what a total hip replacement would look like. Now, we're also assuming that your marketing team has pre-qualified the patient and has done some direct-to-consumer approaches. But as a next step, Dr. Hesney, I'll let you sort of walk through a patient journey and talk about those touch points along the different stages throughout the care continuum, and maybe give us some examples on how you see those 3 patient education strategies coming to life.
Sure. So the decision we're going to discuss is Paul's journey through a hip replacement. So Paul's a 59-year-old man with osteoarthritis of his hip. For quite some time, he's been having pain, and it's getting to the point where it's limiting his ability to do the things that he really wants to do. So he makes an appointment with his primary care provider, and they've discussed that he's tried conservative treatments like physical therapy and non-steroidal anti-inflammatories. But he really wants to know if there are other options. So his primary care provider shares with him a decision support tool which follows international guidelines about how to support his decision. It includes medical facts about the procedure, a decision of his options, and a clarification of his preferences. It allows him to make an informed decision with his provider. It means that it's going to be the right decision for himself, and additionally, the system gets the right candidates for surgery. So when patients are partners in their care like this, They're more likely to adhere to treatments, and ultimately they're going to be more satisfied with their care. So we have to start to prepare Paul for his care episode, and he decides on a hip replacement. But like all medical decisions, he's still nervous and feels, but given the information he has, he's much more comfortable with his decision. He knows his team understands his preferences and cares about the outcomes, and overall he is much more satisfied with the experience. So education needs to start early, and it needs to be given often. Educating Paul pre-surgically can help him understand his procedure. It can help him understand what to expect from that procedure. It can also teach him how to prepare for the procedure to make it less likely that there's going to be a cancellation of that procedure. And because inpatient care episodes are so short, it can also start to prepare him for discharge. The value of education is borne out in the literature. A study on early recovery after surgery showed that patient education not only helped decrease the length of stay, but lowered complication rates as well. And it's not just about the written word. Different people have different learning styles, and we need to provide content in format that works best for the individual. So we have to engage people in effective and familiar ways. When talking about videos, if you give short videos that are written in language that people can understand with simple, clearly defined learning objectives, and available in multiple settings, that will make all care better. With guidance and resources like this, the patient, Paul, can be more confident, he's motivated and understands how to best prepare for surgery, and that can reduce his stress level, which can also help improve his outcomes. And then moving to the inpatient setting. The care team can work with Paul to review the information that he's already gotten. They can provide additional information to help Paul. This may help your system meet quality measures. One system we worked with had an initiative to prevent falls, and that initiative was called Nobody Walks Alone, and they used a whole suite of education to reinforce that initiative. So education delivered to patients not only makes care better, but supports those quality initiatives that you're working on, as well as support accreditation measures like those through NCQA and the Joint Commission. These include things like preventing falls that I already mentioned, but also preventing infections, identifying and treating sepsis early, and avoiding venous thromboembolism. This information helps patients recover more quickly, makes them more satisfied with their care, and it can help avoid inpatient complications that could lead to unnecessary care and unnecessary costs. So then moving to discharge. Discharge in a lot of ways is more important because you will not have as close contact with Paul, and there's less communication that Paul will have with his care team. The information he has learned inpatient and prior can be reinforced, and it really, again, allows for that consistent message that's given both inside and outside the four walls of the institution. At discharge, you can provide information that's easy to understand with clear next steps. It can help Paul review the procedure that he just had, know what he can do at home to take care of himself, and help him identify problems early, such as recognizing a blood clot or recognizing a wound problem. At that point, you can also give him information about when to call for help and who to call. And over the next few weeks, because Paul has been educated and because he's comfortable with his care, he notices a low-grade temperature. He knows that this is something that he needs to call his provider for. And perhaps this is an infection of his incision, or maybe this is a sign of early sepsis. Having him get care at this point and understanding what he needs to do will help him avoid problems like a readmission or an unnecessary emergency department visit. So at home, instructions can help reinforce messages and motivate patients to be active participants in their care. Information should be designed for patients as well as their caregivers. that information needs to be clear and easy to understand. In addition to using the written word, you need to use visuals to teach. They need to be able to be delivered in a written form and electronically fulfilled so patients and caregivers can reference the materials at any time, at any place, or on any device. And I don't want to leave care coordinators out of these episodes of care. The whole team is part of the care and has visibility to what has been delivered and what the patient has interacted with. As part of Paul's care, his physician gave him rehabilitation exercises delivered electronically at discharge. But if you take a care coordinator as part of an outbound call who follows up with Paul and to see how he's doing and to see if he has any questions, that care coordinator can see that he has not yet viewed the information. It's an opportunity for that care coordinator to connect with Paul, to identify any barriers to care, and to reinforce the value of those exercises. So because bundled care includes follow-up for 90 days, it's important to stay connected to Paul. Education all along the episode can do so much and can be tailored to the appropriate moment in care. It can help Paul identify barriers to recovery. It can help him recognize complications early. It can provide him support and information about things we often forget about that the patient has questions about, like diet, bathing, and activity. And ultimately, it puts Paul in the center of that care and can help enhance his recovery.
That's great. So a lot to think about, but we wanted to give you a few steps to get started on mapping those journeys. First of all, we talked a little bit about having a consistent source of education for patients wherever they go for information. Talked about mapping education to the care plan for all different stages in the clinical episode, making education available and accessible to patients at any time, whatever device they're using, and making sure to give care teams the visibility they need to how patients are engaging with education across the different care settings. So all in all, it's going to help people understand their health better. It's going to help them adhere to those care plans, and it will help you achieve the goals of BPCI and BPCI Advanced, which I know many of you are participating in. So at this point in time, we'd love to take some questions.
Great. Thank you both for sharing those insights. And we'll now move on to the Q&A portion of the event. So there's still some time to submit your questions using the Q&A button at the bottom of your screen. We have lots of great questions already, and we'll try to get to as many as possible. So our first question is, we have a lot of dual eligible patients, and we tried to give them the information they need, but we have no way of knowing if they understood it or if it was helpful. How do you ensure that patient education is easy to understand for people with low reading levels?
So great, thanks for that question. So one, you want to make sure that content is written at an appropriate reading level, and you want to think about health literacy as more than just reading level, because reading level is only one measure of how well a patient can understand information. So it's important to write in what we call plain language, which is language that consumers can understand, to use sentence structures that are familiar to them and that are easy for them to understand. So when delivering patient education, you want to make sure that patients have an opportunity to give feedback on that information. You want to make sure that you're also doing user testing on that information to make sure that the learning objective that you set out to adhere to is the one that is met by that piece of information. And those are things that you can do as part of a good health literacy program that can find ways to connect with consumers, not just with reading level, but with plain language and good user testing.
And we do know from previous research that the dual eligible population does have a much lower health literacy and does have the potential to incur a lot more costs just because they don't understand how to navigate their own care. So really good question specifically relative to that population.
All right, our next question is, You talked about the importance of maintaining consistent patient education, but I'm often working with several different systems depending on the department. How do we standardize patient education across so many different platforms?
Good question. So there's been a lot of progress in technology on this front. We should be excited about living in this time because there are new standards. New standards such as FHIR, which Fast Healthcare Interoperability Resources. It's allowing the modern internet to be presented within some of these different platforms, these varying systems across your organization. And we understand that there's a lot of fragmentation amongst these different systems, and so standardizing across all of them is traditionally has been quite difficult. But fortunately, through some of the progress that's been made at a national level to implement new standards, there are a lot of different vendors, there are a lot of different organizations that are working with these standards to better be able to share data, to better be able to share interfaces, and to essentially, when it comes down to it, standardize the interface so that they have an expectation across the organization of what they're going to get, no matter the system.
And I would just add to that, Josh, you talked about the technical aspects of standardizing across systems. You also want to make sure of the medical aspects of it, so that when you're providing information, you're providing it from a source that's going to have mechanisms to continue to keep that information consistent and accurate across all of those settings.
Absolutely.
All right, so moving on to the next question. How is the patient education and plan of care linked to the EMR? What measurements gauge success of the bundle?
Sure. So I think it's important to look at how patients have traditionally engaged with content. If you don't have sort of a baseline to work from, there are a number of resources that you can tap into. We've actually worked with many health systems to help identify some key performance indicators. But making sure, so a good example would be how long is a patient watching a video from the patient portal? We know that patient portal uptake can be sometimes slow. So how can we encourage further utilization of that patient portal? And with a lot of the analytics you've been tracking internally, I know that likely at your health system, if you're at a health system, you're tracking the internal KPIs on that portal. So looking to see how they're currently engaging with content on the portal, and perhaps after implementing some new education standards, how they're engaging following that would be a good measurement of success.
And next, what are your thoughts from a broad perspective on commercial payers integrating bundle payments?
Yeah, so I know that commercial payers always tend to follow suit after a certain amount of time on some of these alternative payment models. I know that they want to prove them out and make sure that they work. But I think, generally that going this way is further emphasis into value-based care and providing mutual accountability on the part of the health system, and it helps us further engage the patient and think of new ways that we can interact with patients and other organizations to share risks. So generally, this is my opinion, my 2 cents, but generally I think it's a good thing.
Great, and how do you measure patient engagement?
So there are a variety of ways that you can measure the engagement of patients. Josh mentioned that if you have dashboards, you can actually see what things patients have viewed, and so that you can get an aggregate information about how people are engaging with the information that you're giving them. And ultimately, as you do studies on your populations, you can start to see how education can impact different quality measures. So we work with institutions that are looking to study those things, which is how does patient education improve engagement, and then how do we start to see reductions in costs or increases in satisfaction?
You know, and I'll add to that a bit. I think that, you know, when you drill down a bit and you're looking at specific metrics, we've looked at everything from, for example, if they're on the portal, time on site would be something that would be interesting. Secondly, how long they've watched a video, if in fact they've opened an email or a piece of education. So your percentage rate, your open rate is always something to pay attention to as well. And then, you know, subsequently, did they take another action? And in collaborating across your organization with perhaps your marketing team or your population health team, you can find out sort of some of the common KPIs that they're working towards, and then how the clinical side can also get involved in that. I think further collaboration between population health departments, the inpatient environments, and the marketing teams is really important in helping develop some of these KPIs, because many of them will be produced digitally, and it depends on how people are interacting with the education content in a digital fashion as to how you can decide what's important as far as your measurements go. So again, that collaboration across the organization and potentially with other organizations on what does success mean? Is it that they just opened it, that they open the education, or is it that we have enough clinicians prescribing or giving education? Those are all things to take a look at when you talk specific metrics.
Great. We have another question for our speakers. Our clinicians are so busy seeing patients in the office, they don't have time to personally check in with each patient to find out if they've read their care instructions or watched a video that was prescribed. What tools are available to help them find that information?
So, Josh mentioned the new integrations with the FHIR standard. So FHIR actually allows you to prescribe information to a consumer. It allows it to be visible. It allows it to be done through an order. It allows it to be visible to the care team. So a care team can see what order something was ordered to a patient. Then they can, all across the whole system by using FHIR can have visibility into what the patient has looked at. And so really the clinician, we know how busy clinicians are, and we understand that to add one additional thing to what they have to do in a day is one too many. And so we want to make this as easy as possible. So by using the FHIR standard, those pieces are visible to the care team to see what the patient has seen and how they've interacted. And like Josh just mentioned previously, you can get to the granularity of have they completed the video, which are the videos that are most popular, that are seen the most.
All right, moving on to our next question. With bundled payments and other value-based payment models proliferating in the healthcare industry, what would you say is the largest barrier to implementing these models?
You know, I think one of the primary barriers is getting everyone on the same page. We know that if you're taking on, if you're sharing risk amongst numerous entities as conveners, even if you're just an episode initiator, it is difficult, number one, to map what happens with the patient currently and what sorts of efficiencies you can gain across the care continuum. But then secondly, if you bring in the factor of all these other organizations and what they're doing, creating a seamless experience for the patient and making sure that you achieve the best outcome across the entire continuum is extremely difficult. And you know, I've said this before, but it's the technical change is easy. The people change is the hardest part, right? So making sure everyone's on the same page, that they're rowing in the same direction, is probably the most difficult aspect to that. So in short, I think culture is a big one. Socializing the concept that, hey, we are doing bundled payments for X, Y, and Z clinical episodes. Let's talk about what that means to the organization, and then bring the appropriate stakeholders together and achieve some consensus as to what does the clinical protocol look like, what does the care pathway look like, what does the patient experience look like, and how can we measure success. So again, figuring out the technology is probably the easiest part of that. The people side is probably the most difficult.
And do you have any thoughts on how to evaluate the effect of bundled payment models and other value-based payment models when a given patient is attributed to multiple models? How do you tease out which model resulted in the savings or improvement in quality and figure out which model to attribute the patient to?
Boy, that is a really difficult question, and I'm not sure exactly one I would be able to answer without specific context, to be completely honest with you. That is a really hard question. But what I do know is, if you're able to engage patients across the entire continuum of care, and you're able to create a seamless experience. So a good example would be bundled payments versus your value-based purchasing for your inpatient Medicare payments. Which one helped you achieve which one affected HCAHPS and which one affected adherence to care plan? It might have been some of the same efforts. How do you attribute it to one model or another? That's really difficult to say which one it was. I think that maybe if you were to map out end to end, which we've seen some service line directors do, we've seen some administrators do, what every single touch point the patient has and what organizational operation and how each one of those things work across the entire continuum of care, you may be able to cull some of those things out. But I do believe it's probably pretty difficult to attribute a patient outcome to one payment model or another, or this organizational effort in this space to improve patient experience and how we attribute it to this particular aspect having not affected the HCAHPS or something along those lines.
All right, moving on to our next question. I'm thrilled to get this new perspective on how we can use patient education to manage costs and reduce readmissions. But readmissions are only one of the quality measures providers are responsible for. How can we use the patient education to meet other quality measures?
So like we said a few minutes ago, there are many different quality measures that clinicians are held accountable for. Patient education, where there's a patient component of those quality measures, engaging patients are always helpful. So whether it is reducing infection, whether it is reducing readmissions, whether it is talking about advanced care, those are all things that when you engage patients and they become part of the care, that you're gonna see increases in your quality measures and help you meet those quality measures.
Great. And how can organizations scale bundled payments and other models across the healthcare industry as we are transitioning to value-based care as an industry?
Sure. So scaling them across maybe different clinical episodes is, I think, what you're asking there. I think that as we've talked to, in fact, I was just talking with a health system that said they're participating, a fairly small health system, participating in 6 clinical episodes, which is pretty impressive. But I think, previous to your application for BPCI, it's really important to identify the service lines or the clinical episodes that you really excel, and then do a proof of concept and really work to have a standardized approach to your next service line or your next clinical episode, and then really scale it from there. I think it's a matter of having confidence in your operations, having confidence in the patient experience, and I know that many of you do have that. But knowing end-to-end, having even just a general view of what's happening from the patient's perspective, and we can talk a little bit about human-centered design, or in other words, having empathy for the patient at each point along the way and then designing around that is going to be really important in scaling, because it won't be that clinicians and administrators are really upset because the first clinical episode didn't work very well and it wasn't financially viable. So initially, if you're just doing 1 or 2 clinical episodes, making sure that they're absolutely the best that they possibly can be, and then considering additional clinical episodes in the future.
All right, next question. Our clinicians and support teams are already so busy. I can't imagine having the time to map specific pieces of content to every stage in a care plan. How can we do this efficiently?
So we do recognize how busy clinicians are, and we're really sensitive to that. We've worked with different systems, and every system has its own specific clinical care plan. So it's important that systems are involved in defining what their particular education care plan is like. But it's important to partner with an organization around education that can help you do those things, that can help you surface the pieces of education content that are going to be important to your clinicians and help you map those to your clinical care plans. But it does have to be a collaborative effort between your clinicians and your partner who's delivering the educational care plans.
Great, thank you. Want to encourage our audience, if there's any questions, to please submit them using the Q&A tab at the bottom of your screen. All right, so that was our last question. We had a lot of great questions today and couldn't get to them all, but we will be getting back to everyone who submitted personally after the webinar. Thank you for attending this Fierce Markets webinar and for submitting great questions. I'd like to thank our speakers, Josh and Adam, for participating, and HealthWise for presenting today's webinar. This webcast has been recorded. You will be able to access the recording within 24 hours using the same audience link that was sent to you earlier. Thank you again for joining, and we look forward to seeing you at future events.